In 5 minutes, we're talking about gloves, packing, and water. So I'm the lead-off 5-minute person. It's really hard to do. There are 22 slides. It's 5 minutes and 6 seconds if I stick with my plan. So we're going to start with talking about lacerations. So not really these kinds of Google images that you can search for, but really just kind of the straightforward laceration that we see almost on a daily basis in the emergency department, with the question of whether or not you actually need to use sterile gloves. Seems like kind of a moot point, but we've actually changed our practice pattern where I work. It's a cost-saving mechanism, maybe it saves a little bit of time. And so the data behind it comes from one randomized trial from the emergency department, done in Canada, from Annals in 2004, basically randomizing people to sterile versus non-sterile gloves. The patients were blinded to that, but obviously the doctors couldn't be. And then a standard protocol for wound repair with follow-up for their follow-up visit. And they actually had a lot of patients, over 800, almost 100% follow-up, which is pretty remarkable in a study like this. And you can see that there's a non-statistically significant difference between sterile and non-sterile gloves, with a trend towards lower infection rates in the non-sterile gloves. So this is really the only ED-based study that's out there. There's a lot of surgical literature with outpatient surgical procedures which supports the same thing. The only caveat to that is that it's sort of a slippery slope, right? We do not work in this kind of environment where everything's clean and cleaned in between every patient or at all, with gowns and drapes, but frequently we're looking for something like this on which to do our suture repair, and on a bad day, sometimes even the red garbage can. So just be careful, because it is a slippery slope. So the gloves are not that important, it seems, but the rest of the care is. So moving on to abscesses. So, that one's ready. And secretly, we all sort of really love them, right? This is from one of my residents' Facebook pages, so I'm kidding. But we love them because there's really nothing more gratifying than that slice and then that gush of pus, right? So the question is whether we need to be packing these or not. So to pack or not to pack. And why is this even discussed? So packing, one, is really painful. So imagine this cavity that's been under a lot of pressure, and now we take a hemostat and we shove a bunch of gauze in there, and then 2 days later, when it's all dry and crusty, we bring them back and we tear that thing out. So not a comfortable procedure at all. Not quite as painful as this. But it's not only painful, it also requires a follow-up visit. So the question is whether it's even evidence-based. So people think that by putting packing in there, you're keeping it open, you're allowing it to drain, you don't allow the infected material to accumulate, and maybe it promotes epithelialization of the inside cavity. So the study that's quoted all the time from the EM literature is by Dr. O'Malley here. So I'm not going to go through all these things, but essentially standard protocol for how they incise the abscesses and then whether or not they packed them. So they randomized a small number of patients, and you can see they didn't have a ton of people who came back for their physical follow-up, but they got phone follow-up on almost everyone. And there was no change in the need for intervention, which was defined as addition of antibiotics, re-incision, or repacking. But the pain score was higher both at the time of procedure and the post-procedure assessment. The pediatric literature also has begun to show some similar data. This is by Dave Kessler at Columbia. Another small study with no difference, although both groups had high intervention rates, so it sort of just questions what they're doing in terms of how they take care of their abscesses. But I think probably the most compelling data is this meta-analysis by Adam Singer from Stony Brook, which basically compared primary closure of an abscess, so you suture it closed after you drain it, versus leaving it open. So a lot of patients, over 900, and you can see that the secondary closure method, which is leaving the wound open like I think we do most of the time, every single outcome is worse. Longer time to healing, more rates of recurrence, more complications, and more time off from work. So if you suture it closed, that sort of, to me, says you don't need to pack it. If you don't need to leave it open, you can actually suture it closed. And lastly, talking about tap water. So a Cochrane review for water, and this is really simple, keeping in the sort of 5-minute theme. I have 48 seconds left. So 11 trials, all for acute wound repair in the emergency department, comparing irrigation with tap water versus normal saline. And you can see that the relative risk of infection for tap water is 0.63, which actually doesn't even cross 1, although it gets almost there. So essentially equivalent to irrigation with normal saline, and may actually be a little bit better. So basically just having somebody put their wound under a faucet. There is one significant complication from this, though. It's not always predictable, but sometimes patients can't actually deal with seeing a sink fill with their blood and wind up like this. And this can actually lead to a traumatic subarachnoid, which we actually had happen in our fast track at Roosevelt. So just be careful and sort of assess the queasy factor before you have somebody stand up at a sink and watch the sink fill with their own blood. It's always the beefy, muscular, like tattooed guys that go down. So, take-home points. Avoid the slippery slope. It's okay to wear non-sterile gloves, but please don't use garbage cans and all these other things to do our wound repairs. Packing is not necessary, and tap water is good and maybe even be better. Thank you.